Good day, everyone. So, today we will be going to report about the reproductive endocrinology. On the screen are the topics that we will cover in this presentation. So, please give your undivided attention to this video. Thank you. Reproductive endocrinology describes the hormones and the control mechanisms that regulate sexual development, sexual function, and reproduction. And in this video, we will be focusing on discussing about the human reproductive endocrinology.
The gonads develop from three sources: the mesothelium or the coelomic epithelium, which is the one lining the posterior abdominal wall, the underlying mesenchyme, or the one also called as intermediate mesoderm, and the primordial germ cell or the PGC. The mesothelium proliferates to form the genital ridge, a bulge of tissue medial to the mesonephores. From this epithelium, primary sex cords penetrate the mesenchyme. The indifferent gonad now consists of a medulla and cortex. In XX embryos, or the female embryos, the ovary will originate from the cortex and the medulla will decline, while in the male embryo, or the XY embryo, the medulla will develop into the testes and the cortex regresses. To elaborate more, male gonad, it is regulated by SRY. The primary sex cords enter the medulla and differentiate into the seminiferous cords. These are the precursors to the seminiferous tubules, which sperm will be produced. The parts of the primary sex cords that extend deepest to the medulla from the root testes. The first in the series of structures by which sperm leaves the testes in adulthood. As the seminiferous tubules are forming, the PGC enter the gonad and associate with the tubules. The PGC will now give rise to sperm after puberty. The cords will give rise to the sustentacular cells of the tubules, which the one we call Sertoli cells. Sertoli cells, the germ cell remain in meiotic arrest in the presence of these cells and are in active spermatogonia until puberty. This phenomenon is due to the secretion of Sertoli cells of anti-Müllerian hormone, or the AMH, which also signals for intermediate mesoderm to differentiate into Leydig cells, which secretes testosterone. So, female gonad. The ovary develops more slowly than the testes. Although the primary sex cords enter the genital ridge at the same time, the ovary cannot be distinguished histologically until the 10th or 11th week. The primary sex cords degenerate and the secondary sex cords extend from the surface epithelium. As these cords increase, the PGC are now incorporated into them. About 16 weeks, these cords break up into isolated clusters called primordial follicles. Each follicle consists of an oogonium, which comes from the PGC, and a single layer of flattened cells that also called follicular cells, derived from cords. Oogonia undergo a period of proliferation. In the absence of SRY, the AMH, PGC undergo the first phase of meiosis. Descent of gonads. While the gonads arise in the upper luminal region, they are each tethered in the scrotum or labia by gubernaculum. Gubernaculum is a ligamentous structure formed from mesenchyme. The testes, as the body of the fetus grow, the testes become more caudal. They pass through the inguinal around 28th week and reach the scrotum by 33rd week. During their descent, the testes retain their original blood supply. with the testicular arteries branching from the lunar aorta. The scrotal ligament is the adult remnant of the gubernaculum. For the ovaries, the ovaries initially migrate caudally in a similar fashion to the testes from their origin on the posterior abdominal wall. However, they do not travel as far, reaching their final position just within the through pelvis. The gubernaculum becomes ovarian ligament and a round ligament of the uterus.
Sexual differentiation. So there are four types of sexual differentiation: the chromosomal sex, gonadal sex, hormonal sex, and morphological sex. And the final is the differences in physiology of those four differentiation. Chromosomal sex. Each human cell contains 46 chromosomes occurring in pairs, 23 pairs of chromosomes, 22 autosomes, and for the 23rd pair are the sex chromosomes. Germ cells. Male produce sperms that contains X or Y, and the female produce ovum contains an X. Y chromosome contains less genetic material than X chromosome. Gonadal differentiation. Undifferentiated gonad develops as germinal ridge off of the protokidney. The gonad at this stage has a medullary and cortical region of gestation. Ovaries develop during the 13th to 16th week. Without TDF input, the cortical region will develop into an ovary, and the medullary region will regress dry, causes development of the medullary region into a testis, and development proceeds from there, resulting from the hormone secreted by the gonads. Hormonal sex. Ovaries fairly quiescent during embryogenesis. They secrete very low of estrogens but don't produce significant quantities of hormones until puberty to repeat. In the absence of hormones from a testis, morphological, neural, and behavioral development is female. For the testes, produce testosterone and proteins from Mullerian inhibiting hormone MHI from the Sertoli cells. Mullerian and Wolffian duct system cervix. The progenitors for the duct systems are present for both male and females embryologically, in contrast to gonadal development, where one gonad becomes either male or female. For the Mullerian versus Wolffian, first, with no hormones, the Mullerian duct develops and the Wolffian duct undergoes programmed cell death, regress, and degenerates. This causes formation of female internal morphology. Mullerian system becomes fallopian tube, uterus, and cervix. Second, with testes present, Leydig cell produce testosterone, cause development of Wolffian duct, turn off programmed cell death. Wolffian ducts become vas deferens, seminal vesicles, and prostate gland. Sertoli cells produce Mullerian inhibitory hormone, cause regression of Mullerian ducts. If the Sertoli cells fail to produce MIH, a male can have both male and female internal structures. Development of male external genitalia is dependent on dihydrotestosterone and androgen. The skin of the genitalia contains the enzyme necessary to convert testosterone to DHT 5-alpha reductase. The testes produce androgens, and in the genital area, that is converted to DHT, causing masculinization of the external genitalia. Both males and females have this enzyme in the developing genitalia, but females have no T to convert at this time, so no DHT produced. If female is accidentally producing T, she can have masculinized genitalia at birth. If male does not produce the enzyme, external genitalia will be female. Brain differentiation. For male, testosterone secreted into the blood reaches the brain. Testosterone converted to estradiol and dihydrotestosterone in the brain. Estradiol masculinizes the brain. For female, alpha-fetoprotein binds to estradiol, prevent estradiol from entering the brain, protects female brains from being masculinized by estradiol brain differentiation. Pathophysiology. For male anomalies, androgen insensitivity syndrome means no functional androgen receptors, and for the 5-alpha reductase deficiency, it cannot produce DHT. For female anomalies, masculinization is exogenous treatment with androgenic steroids and endogenous production of androgenic steroid. For chromosomal abnormalities, Turner syndrome is lack of damage for second chromosome.
The male reproductive system includes a group of organs that make up a man's reproductive and urinary system. These organs do the following jobs within your body. First, they produce, maintain, and transport sperm and semen. Second, they discharge sperm into the female reproductive tract. And lastly, they produce and secrete male hormones. The male reproductive system is made up of internal and external parts. Together, these organs help you urinate, have sexual intercourse, and make children. The entire male reproductive system is dependent on hormones. These are chemicals that stimulate or regulate the activity of their cells or organs. The primary hormones involved in the functioning of the male reproductive system are follicle stimulating hormone, luteinizing hormone, and testosterone. SSH and LH are produced by the pituitary gland. It's located at the base of your brain and it's responsible for many functions in your body. FSH is necessary for sperm reproduction. LH stimulates the production of testosterone, which is necessary to continue the process of spermatogenesis. Testosterone is also important in the development of male characteristics, including muscle mass and strength, fat distribution, bone mass, and sex drive. This illustration shows the regulation of reproductive hormone secretion in males. First is the gonadotropin releasing hormone from the hypothalamus stimulates the secretion of luteinizing hormone and follicle stimulating hormone from the anterior pituitary. Second, LH stimulates testosterone secretion from the interstitial cells. Third is the FSH stimulates sustentacular cells of the seminiferous tubules to increase spermatogenesis and to secrete inhibin. Fourth, testosterone has a stimulatory effect on the tentacular cells of the seminiferous tubules as well on the development of reproductive organs and secondary sexual characteristics. Fifth, testosterone has a negative feedback effect on the hypothalamus and pituitary to reduce GnRH, LH, and FSH secretion. Lastly, 6. Inhibin has a negative feedback effect on the anterior pituitary to reduce FSH secretion. Prolactin comes from the front part of the pituitary, which is called the anterior pituitary. Prolactin is a protein hormone whose major target cells is the mammary glands. Secretion of prolactin increases during pregnancy and nursing. It stimulates mammary gland development and enlargement, as well as milk production. Secretion of oxytocin increases towards the end of pregnancy when it stimulates uterine contractions during labor and after pregnancy. When it stimulates milk let down from the mammary glands to the nipple. This
And now let's proceed to the female reproductive and its hormonal functions. The female reproductive has three major roles. And first, the female reproductive produces and sustains female sex cells or the egg cells or the ova. Next, female reproductive transports these egg cells to a site where they may be fertilized by the sperm, then eventually provides a favorable environment for the developing fetus and deliver the fetus to the outside at the end of the development period. The female reproductive systems includes the ovaries, fallopian tubes, uterus, vagina, accessory glands, and external genital organs. There are four hormones involved in female reproductive, and that includes the luteinizing hormone, which helps control the menstrual cycle, the follicle stimulating hormone, which also helps control menstrual cycle and stimulates the growth of eggs in the ovaries, and lastly, the female sex hormones, the estrogen and the progesterone, helps develop and maintain both the reproductive system and the female characteristics, which makes female unique. There are three main factors affecting the production of hormones in females. First is the menstrual cycle, the pregnancy, and the menopausal stage. Now we will be discussing the menstrual cycle. Menstrual cycle in females first happen during puberty, and there are three phases in menstrual cycle, which are the follicular phase, the ovulatory, and the luteal phase. The menstrual cycle begins with menstrual bleeding or the menstruation, and that marks the first day of the follicular phase. When the follicular phase begins, levels of estrogen and progesterone are low. As a result, the top layers of the thickened lining of the uterus or the endometrium break down and are shed. The menstrual bleeding occurs. About this time, the follicle stimulating hormone level increases slightly, stimulating the development of several follicles in the ovary. Each follicle contains an egg, and later in this phase, as, as the follicle stimulating hormone level decreases, only one follicle continues to develop, and that follicle produces estrogen. Next is the ovulatory phase. Ovulatory phase begins with a surge in luteinizing hormone and follicle stimulating hormone levels. This means there is a sudden increase of luteinizing and follicle stimulating levels. Luteinizing hormone stimulates ovulation, which usually occurs 16 to 32 hours after the surge begins. The estrogen level decreases during the surge, and the progesterone level starts to increase. The last phase is the luteal phase. During the luteal phase, luteinizing hormone and follicle stimulating hormone levels decrease. The ruptured follicle closes after releasing the egg and forms a corpus luteum, which produces progesterone. During most of this phase, the estrogen level is high. Progesterone and estrogen cause the lining of the uterus to thicken more to prepare for a possible fertilization. If the egg is not fertilized, the corpus luteum degenerates and no longer produces progesterone. The estrogen level decreases, the top layers of the lining break down and are shed, and menstrual bleeding occurs. And then a new cycle of menstruation occurs. If the egg is fertilized, the corpus luteum continues to function during early pregnancy. because it helps maintain the pregnancy. The next factor is the pregnancy. During pregnancy, estrogen and progesterone are the chief hormones. The increase of these hormones during pregnancy enables the uterus and placenta to improve vascularization. And it also enables transfer nutrients from the mother down to the developing baby. And generally, the changes in estrogen and progesterone support the developing baby. In addition, estrogen is thought to play an important role in helping the fetus develop and mature. Estrogen levels increase steadily during pregnancy and reach their peak in third trimester. The rapid increase in estrogen levels during the first trimester may cause some of the nausea associated with pregnancy. During the second trimester, it plays a major role in the milk duct development that enlarges the breasts. Progesterone levels also are extraordinarily high during pregnancy. The changes in progesterone cause a laxity or loosening of ligaments and joints throughout the body. In addition, high levels of progesterone cause internal structures to increase in size, such as the ureters. The ureters connect the kidneys with the maternal bladder. Progesterone is also important for transforming the uterus from the size of a small pear in its non-pregnant state to a uterus that can accommodate a full-term baby. The last factor is the menopausal stage. During menopausal stage, there is a great changes in hormones in females. Naturally, ovaries also make the hormones estrogen and progesterone, which control menstruation and ovulation. But oocytes in females are numbered. When menopausal stage occur, this is a natural thing to happen in every female during their late 30s, where ovaries start making less estrogen and progesterone, and until ovaries no longer release an egg every month and menstruation stops.
And now, let us proceed to pregnancy. During pregnancy, a woman experiences a change in her endocrine system. Throughout pregnancy, the levels of progesterone and estrogen increase, the estrogen being produced by the placenta and the progesterone being produced by the corpus luteum and later by the placenta. Increase in estrogen levels results in an increase in hepatic production of thyroid-binding globulin. As a result, more free T3 and T4 bind to the DBG. This causes more thyroid-stimulating hormone to be released from the anterior pituitary gland. Therefore, the free T3 and T4 levels remain unchanged, but the total T3 and T4 level rises. Thyroxine is essential for the fetus neural development, but the fetal thyroid gland is not functional until the second trimester of gestation. Hence, increasing T3 and T4 levels in the mother ensures that there is a constant supply of thyroxine for the fetus early in pregnancy. During pregnancy, there is also an increase in human placental lactogen, prolactin, and cortisol levels. These are anti-insulin hormones. Therefore, they increase insulin resistance in the mother that reduce peripheral uptake of glucose. This ensures that there is a continuous supply of glucose for the fetus. The mother switches to an alternative source of energy, which is provided by the lipids. The increase in lipolysis means that there is an increase in free fatty acids in the plasma, which provides substrate for maternal metabolism. The breakdown of lipids can result in ketogenesis, thus pregnancy is associated with an increased risk of ketoacidosis. During pregnancy, the placenta, which connects to your baby to your blood supply, acts as a temporary endocrine system, which is the hormone producing gland producing large amount of estrogens and progesterone to help the uterus grow. Hormonal changes during pregnancy affect the interbody system. Here are just a few ways the endocrine system responds during pregnancy. Increase in hormone levels and metabolic rates may cause pregnant women to feel warmer or have hot flashes. Next, the parathyroid gland grows slightly bigger to meet the increased need calcium. Third is when the baby is ready to be born, the posterior pituitary gland will secrete oxytocin to initiate labor. And lastly, at birth, the anterior pituitary will secrete prolactin to stimulate the production of milk. Here are the list of the common endocrine disorders that can occur in pregnancy. One is the gestational diabetes, where pregnancy causes your body to produce high levels of various hormones. And the last is the thyroid disease during pregnancy, where thyroid disease is the second common endocrine condition in women of childbearing age after diabetes.
Parturition. Parturition is the process of giving birth, occurs at the end of the gestation period or pregnancy, involves the orchestration of a complex series of physiological events that require the rotation of the fetus into the birth position, which is accompanied by a cascade of endocrine changes that terminate with a successful delivery, constitutes transport of the fetus and its associated membranes from the maternal to the external environment, and represents transition of the fetus to a neonate. Considered as a very critical management phase in the production cycle of livestock. Timing of parturition is important. Parturition before term increases mortality and morbidity risk for the neonate due to insufficient in utero development and functional immaturity of organ systems needed to survive outside of the uterus and independent of the placenta. Parturition after term increases mortality and morbidity risk for mother and neonate due to fetal overgrowth and the associated problems with labor and delivery. So this is the three stages of parturition. First, preparatory stage. Second, expulsion stage. And three is the cleaning stage. Preparatory stage. Dilation of cervix is manifested. The female prepares to give birth, occurrence of mucus discharge from the vulva, decreased body temperature, filling of mammary glands with milk, and mild straining is possible. For the latent phase, the cervix is 0 to 4 centimeters dilated, and the active phase, the cervix is 4 to 10 centimeters dilated. Expulsion stage. The female prepares to give birth. Walls of the uterus begin to contract more frequently. Officially begins with the appearance of membranes, or what we call the water bag, at the vulva. Occurrence of delivery pushing the fetus into the birth canal. For passive phase, the baby's head moves down through the vagina, and the active phase, the mother feels a need to push or contract the abdominal muscles in time with uterine contractions. Cleaning stage. Placenta is shed from the body. If the fetal membranes and fluid remains, this can become infected and lead to serious illness and possible death of the mother. After removal of placenta and the shedding of uterine lining, the uterus can begin to contract back to the significantly smaller size that is maintained when the entity is not pregnant. Involution is the process by which the uterus shrinks back to its normal size. Phase 1. quiescence, prelude to parturition. Contractile unresponsiveness, cervical softening. For the phase 2, activation, preparation for labor. Uterine preparedness for labor, cervical ripening. In the phase 3, stimulation, processes of labor. Uterine contraction, cervical dilation, fetal and placenta expulsion. The 3 stages of labor. For the phase 4, involution, parturient recovery, uterine involution, cervical repair, breastfeeding. That's all. Thank you.
Lactation is the process of producing breast milk. For women who are pregnant or recently gave birth, lactation is normal. Hormones signal the mammary glands in your body to start producing milk to feed the baby. But it's also possible for women who have never been pregnant and even men to lactate. This is called galactorrhea, and it can happen for a variety of reasons. New environment. The mother's body has to prepare to take care of her newborn. Around the 6th month of pregnancy, the mother's body prepares to produce milk for the coming newborn. First, the mammary glands in the mother's breast enlarge and have fully developed by month 6. These glands are like enlarged and slightly modified sweat glands. They contain cells that produce colostrum and milk under the influence of the hormone prolactin. Because these glands secrete their product that's milk outside the body, they are called exocrine glands. Once milk has been produced, it needs to travel from the mammary gland to the nipple. This is under the influence of another hormone called oxytocin, as well as the presence of myoepithelial cells which surround the mammary glands. Myoepithelium cells are similar to muscle cells. They contract and push the milk out of the mammary glands and down ducts towards the nipple. This process is known as milk letdown. These hormones work together to trigger lactation or the production and secretion of milk from the mammary glands. Let's look at the steps involved. First is the crying of the baby as well as thoughts of your baby or even the crying of another baby can stimulate the hypothalamus, which in turn stimulates the release of prolactin and oxytocin from the pituitary. Second is the when the baby starts to suck at the nipple, a physical stimulus is sent to the mother's brain, which causes more oxytocin and prolactin to be released. Third, prolactin and oxytocin travel to the mammary glands where prolactin stimulates the production of milk in the glands and oxytocin stimulates the myoepithelial cells to push milk from the glands down to the ducts and towards the nipple. And lastly, fourth, milk gathers at the nipple and is released into the baby's mouth. This is called a positive feedback loop because as long as the baby keeps suckling, milk release will continue. To stop the positive feedback loop, the physical stimulus of suckling needs to be removed.
Let us proceed on some disorders that might be encountered when talking about reproductive endocrinology. First is the premature or primary ovarian insufficiency. This occurs when the ovaries stop functioning as they should before age of 40. When this happens, your ovaries don't produce typical amounts of hormones estrogen or release eggs regularly. This condition is also called premature ovarian failure and often leads to infertility. Primary ovarian insufficiency is sometimes confused with premature menopause, but these conditions aren't the same. Women with primary ovarian insufficiency can have irregular or occasional periods for years and might even get pregnant. But women with premature menopause stop having periods and can't become pregnant. Restoring estrogen levels in women with primary ovarian insufficiency helps prevent some complications that occur as a result of low estrogen, such as osteoporosis. Signs and symptoms of primary ovarian insufficiency are similar to those of menopause or estrogen deficiency. They include irregular or skip periods, which might be present for years or develop after a pregnancy or after stopping birth controls like pills. Difficulty getting pregnant, hot flushes, night sweats, vaginal dryness, dry eyes, irritability or difficulty concentrating, and decreased sexual desires. Primary ovarian insufficiency may be caused by chromosome changes, toxins like the chemotherapy and radiation therapy are some causes of toxin-induced ovarian failure, an immune system response to ovarian tissue, or the autoimmune disease is a rare form. Your immune system produces antibodies against your ovarian tissue, harming the egg containing follicles and damaging the egg, and also some unknown factors. Factors that increase your risk of developing primary ovarian insufficiency includes age, family history, ovarian surgery. Complications of primary ovarian insufficiency includes infertility or the inability of getting pregnant, osteoporosis, where estrogen hormones can help in maintaining the strong bones, depressions or anxiety, where the risk of infertility and other complications arising from low estrogen levels causes some women to become depressed or anxious. Heart disease, where early loss of estrogen might increase your risk. Currently, there is no proven treatment to restore normal function to a woman's ovaries, but there are ways on how to lower the risk and treat conditions that primary ovarian insufficiency can cause. Some of these are the hormone replacement therapy, calcium and vitamin D supplements, in vitro fertilization, regular physical activity and healthy body weight, and treatment for associated conditions.
So, the next disorder we will be discussing is the hirsutism. It is a condition in women that results in excessive growth of dark or coarse hair in a male like pattern. It can be found in the face, chest, and the back. With hirsutism, extra hair growth often arises from excess male hormones, primarily the testosterone. When high androgen levels causes hirsutism, other signs might develop over time, a process called virilization. Signs of virilization might include the deepening of voice, balding, acne, decreased breast size, increased muscle mass, and enlargement of the clitoris. Hirsutism may be caused by polycystic ovarian syndrome or the PCOS. This condition, which often begins with puberty, causes an imbalance of sex hormones. Second is the Cushing syndrome. This occurs when your body is exposed to high levels of the hormone cortisol. Third is a congenital adrenal hyperplasia. This inherited condition is characterized by abnormal production of steroid hormones. Next and last is the tumors. It is very rare. An androgen secreting tumor in the ovary or adrenal gland can cause hirsutism. The risk factors can influence your likelihood of developing hirsutism includes family history, ancestry, and obesity, where being obese causes increased androgen production, which can worsen hirsutism. So for the complications, hirsutism can be emotionally distressing. Some women feel self-conscious about having unwanted hair. Some develop depression. Also, although hirsutism doesn't cause physical complications, the underlying cause of a hormonal imbalance can. If you have hirsutism and irregular periods, you might have polycystic ovarian syndrome, which can inhibit fertility. Women who take certain medications to treat hirsutism should avoid pregnancy because of the risk of birth defects. For the treatment, hirsutism generally isn't preventable, but losing weight if a person is overweight might help reduce hirsutism, particularly if a person has PCOS. Some procedures might help in preventing hirsutism, includes temporary hair removal, hair growth production or hair growth reduction, long-lasting hair removal, and medical treatment.
The next disorder is amenorrhea. Amenorrhea is the absence of menstruation after a female's puberty age. There are times when females are not supposed to have their period, such as before puberty age, during pregnancy, and after menopause. But if the puberty age had passed and still did not have the first period, this is a sign of amenorrhea. And in another case, even if a woman does have her period at the right age, yet does not have a regular monthly period, this is also a symptom of amenorrhea. There are two types of amenorrhea. First is the primary amenorrhea. This is the absence of menstruation after the age of 15. Causes of this are chromosomal or genetic problem with ovaries and hormonal issues with hypothalamus or the pituitary gland. The second type is called secondary amenorrhea. This is the absence of three or more periods in a row who had experienced periods in the past. Pregnancy is the most common cause of secondary amenorrhea, although problems with hormones also can cause secondary amenorrhea. The following are the symptoms that can be observed in an individual who has amenorrhea: milky nipple discharge, hair loss, headache, acne, vision changes, excess facial hair, and pelvic pain. Risk factors of amenorrhea includes family history of amenorrhea or early menopause, genetic or chromosomal condition that affects your menstrual cycle, obesity or being underweight, eating disorder, over-exercising, poor diet, stress, and chronic illness. There are ways to treat amenorrhea. First is the proper diet and exercise. The proper food intake must be considered. If excess weight is the cause of amenorrhea, losing weight through dieting and exercise must be done. And if extreme weight loss is the cause, gaining weight through an individual's diet plan will do. Next is therapy. Therapy such as stress management techniques has been one of the treatment of amenorrhea. Next is hormonal medication or taking pills. Taking hormonal medication has been approved in treating amenorrhea because birth control pills or other hormone therapies can restart the female's menstrual cycle. Amenorrhea caused by thyroid or pituitary disorders may be treated with medication. And lastly is surgery, but surgery is very rare in amenorrhea. These treatments can be applied in both types of amenorrhea. Next is PCOS or polycystic ovary syndrome. Polycystic ovary syndrome is a hormonal disorder common among women of reproductive age. Women with PCOS may have infrequent or prolonged menstrual periods or excess male hormone or the androgen levels. Within the age of 15 to 44, 2 to 27% of women have PCOS, and 70% of this population don't know that they have it. The lack of ovulation alters levels of estrogen, progesterone, follicle stimulating hormone, and luteinizing hormone. Progesterone levels are lower than usual, while androgen levels are higher than the usual. Extra male hormones disrupt the menstrual cycle, so women with PCOS get fewer periods than usual. Signs and symptoms of PCOS vary. A diagnosis of PCOS is made when you experience at least two of these signs. First is the irregular periods. Infrequent, irregular, or prolonged menstrual cycles are the most common signs of PCOS. For example, you might have fewer than 9 periods a year, more than 35 days between periods, and abnormally heavy periods. Next is excess androgen. Elevated levels of male hormones may result in physical signs such as excess facial and body hair or the hirsutism and occasionally severe acne and male pattern baldness. Next is the polycystic ovaries. Your ovaries might be enlarged and contain follicles that surround the eggs. As a result, the ovaries might fail to function regularly. Risk factors of PCOS includes genetic. PCOS can be genetically acquired, especially if the family has history of PCOS. Next, stress. Stress may trigger hormonal imbalance, especially in females, which results polycystic ovary syndrome. And lastly is lifestyle. Even a lot of women already suffered from PCOS. The treatment of this disorder is still unknown. But in early diagnosis and treatment along with PCOS, weight loss may reduce the risk of long-term complications such as type 2 diabetes and heart disease. Hypogonadism, or low testosterone, is a condition in which the testes do not produce enough testosterone. Low testosterone affects almost 40% of men aged 45 and older. It is difficult to define normal testosterone levels because levels vary throughout the day and are affected by the body mass index or the BMI, nutrition, alcohol consumption, certain medication, age, and illness. Male hypogonadism means the testicles don't produce enough of the male sex hormone testosterone. There are two basic types of hypogonadism. First is their primary hypogonadism. This type of hypogonadism, also known as primary testicular failure, originates from a problem in the testicles. Next is the secondary hypogonadism. This type of hypogonadism indicates a problem in the hypothalamus or the pituitary gland, parts of the brain that signals the testicles to produce testosterone. The hypothalamus produces gonadotropin releasing hormone which signals the pituitary gland to make follicle stimulating hormone and luteinizing hormone. Luteinizing hormone then signals the testes to produce testosterone. The following are the symptoms of hypogonadism: low sex drive, erectile dysfunction, decreased sense of well-being, depressed mood, difficulties with concentration and memory, fatigue, moodiness and irritability, loss of muscular strength. You may think that you have experienced most of these symptoms and now you are personally diagnosing yourself with this disorder. Stop. You are just overthinking. A consultation from a medical professional must be done, and they are the only who can diagnose patient with this disorder. Factors that can increase the risk of hypogonadism include HIV/AIDS, previous chemotherapy or radiation therapy, aging, obesity, malnutrition. The treatment of hypogonadism includes intramuscular injection, testosterone patches, which are used every day and are applied to different parts of the body, including the buttocks, arms, back, and abdomen. Testosterone gels that are applied every day to the clean, dry skin of the upper back and arms. The gels require care in making sure that the hormone is not accidentally transferred to another person or partner. pellets that are implanted under the skin every 2 months. The next disorder is the prostate cancer. Prostate cancer is a cancer that occurs in the prostate. The prostate is a small walnut-shaped gland in males that produces the seminal fluid that nourishes and transports sperm. Prostate cancer is one of the most common types of cancers in male. Many prostate cancers grow slowly and are confined to the prostate gland, where they may not cause serious harm. However, while some types of prostate cancer grow slowly and may need minimal or even no treatment, other types are aggressive and can spread quickly. The symptoms of prostate cancer are troubling urinating, decreased force in the stream of urine, blood in the urine, blood in the semen, bone pain, losing weight without trying, erectile dysfunction. Factors that can increase the risk of prostate cancer include older age. The risk of prostate cancer increases as one ages. It is most common after the age of 50. Race. For reasons yet not determined, African American people have a greater risk of prostate cancer than do people of other races. In Black people, prostate cancer is also more likely to be aggressive or advanced. Next is family history. If a blood related, if a blood relative, such as a parent, sibling, or child, has been diagnosed with prostate cancer, your risk may be increased. Also, if you have a family history of genes that increased the risk of breast cancer, or a very strong family history of breast cancer, your risk of prostate cancer may be higher. And lastly is obesity. People who are obese may have a higher risk of prostate cancer compared with people considered to have a healthy weight. Though studies had mixed results, in obese people, the cancer is more likely to be more aggressive and more likely to return after initial treatment. So to prevent prostate cancer, the only advice is to have a healthy diet and regular exercise. And to treat this kind of cancer, cryotherapy and chemotherapy are usually done. And also, prostatectomy is one of the most common surgery in treating prostate cancer, which is the removal of prostate gland.